the orthoPAC, hosted by Sam Dyer. Welcome to the orthoPAC, where we discuss up-to-date orthopedic topics for the busy clinician. I invite you to sit back and relax as I attempt to fill in the gaps between education, current events, and real-world practice.
Welcome today, Dr. Silverberg. Dr. Silverberg's a radiologist out of Charlotte, and he recently gave a talk at our Charlotte meeting about trauma imaging. I'm so excited to have him on the podcast today. Just for a point of reference, there will be some images posted on our YouTube channel. So when you're listening to the podcast, if you'd like to see some images that kind of correlate to the topics we're discussing, please tune into that. So Dr. Silverberg, welcome.
Appreciate the opportunity.
You talked some about osseous pathology and the Wolff law and Mechanostat theory, and I don't want to go down that too far, but you have a very nice slide on that kind of explains what it means. Would you mind going through that a little bit and just telling our listeners what's meant by the Wolff law and Mechanostat theory and how that's relevant for osseous pathology?
Sure. And I feel like, I will do my best to keep this brief, but I feel like I'll do a disservice to Wolff and the other physician that came up with Mechanostat by summarizing. But essentially, there's a saying that we never treat an image, we treat a patient. And I think when we look at images, we have to take a step back and realize, this is a patient. It's not just pictures, right? So understanding things like Wolff's law and how it applies to imaging is same with Mechanostat and how it applies to imaging really helps us to understand the significance of what we're actually seeing on that image. So Wolff's law on bone, to summarize, is just a law or theory created by a surgeon, just explaining how bones respond to stress. So for example, if we look at the upper extremity in a right-hand dominant professional tennis player and compare that to their contralateral side, it's very common that dominant hand that they use the racket in is going to have thicker bones than a non-dominant side. Well, why is that? It's basically a result of that bone reinforcing itself. It becomes thicker because thicker bones are less prone to fracture and stress-related injury. So it's the bone that is kind of changing in response to stress. And that's basically what Wolff's law says. The Mechanostat theory kind of improved upon that because Wolff's law is not a perfect description. And Mechanostat theory is kind of seen as Wolff's law version 2, essentially. And it better describes how bones model and remodel. What we mean by that is remodeling is a normal function. All of our bones remodel. Just, in an average year, I think it's 10% or less, or maybe 15% or less of our bones that remodel just in response to our normal daily activities, kind of taking out the old bone and putting in the new. Or if we have an area of bone that's being exposed to more stress, more bone is deposed in that area and less bone is deposed in a different area. And it's just a way of changing the makeup of the bone. It's not changing what the bone is made of. It's changing the distribution of the components of the bone to support or scaffold, essentially, areas that are placed under more stress. And so that's important in patients that don't weight bear. And we get osteopenia, right? Because they're taking bone away from areas and putting it in places that would benefit from using more bone. So if someone's not weight bearing in the lower extremity, that bone's not being utilized. It's going to be remodeled and bone's going to be taken away. In the opposite end of the spectrum, if someone is constantly, exposing a bone to higher stress, let's say a runner, in the calcaneus or something like that, or metatarsals, they're going to need a little bit more bone deposed because they're exposed to more stress. So this is really important to kind of understand because when we look at images, we're seeing that in action. We're seeing these bones remodel, and that could be pathologic or it could be physiologic. And that's kind of what we need to suss out. So a great example of this, and I think an example that is relevant to kind of so many paths in orthopedics, is medial tibial stress syndrome, because it's a spectrum of pathology. It starts when the muscle and bone interface is overloaded along the tibial periosteum, and then it can progress all the way to cortical fracture. So there's a classification or grading system in use called the Fredrickson classification system. I'm not sure if you guys use that. I don't really harp on classification systems, but I think it's just a good example of literally every spectrum of kind of stress response or the Mechanostat theory in action. In the lowest grade of medial tibial stress or shin splints, it's due to a traction periostitis, where that tibialis anterior tugging at the interface of the attachment of bone to the anterior tibial cortex. And it's overloading the tibial periosteum. It's tugging, tugging, tugging. So in the early stage, the only manifestation on imaging is just a little bit of periosteal fluid. So on a fluid sensitive sequence, we see this little bright signal that goes along the anterior cortex tibia. And that's literally it. That's the only finding. So if we take a step back and we look at that, most people say, oh, a little bit of fluid, it could be nonspecific. But again, putting it in the context of the Mechanostat theory, that bone is remodeling. That tiny little fluid, that little subtle finding is telling us that bone is being exposed to a higher degree of stress than it can handle, and the remodeling process may begin. Now, we take that patient, give them rest, let them recover, and then they go back. That remodeling is over. Now that bone, that periosteal and muscle interface can withstand higher stress. So that's why shin splints get better, right? Because the patient's remodel. Now, let's say that patient doesn't rest and they keep going and they keep running. They're exposing now that bone to a chronic repetitive stress at a higher and higher degree. And eventually, that will lead to a fracture. So what we see on imaging is we get that little bit of fluid around the cortex. It continues to progress. They get marrow edema within the medullary cavity. Again, on a fluid sensitive sequence, edema is bright. It's going to be bright signal in the medullary cavity. Usually starts along the endosteum. Once it gets worse, goes through the entire medullary cavity. And if we keep going and we don't kind of intervene clinically, that then will be transmitted to the cortex, and we get a cortical fracture. A fracture will be bright signal on a fluid sense sequence in normal dark cortical bone. So that I think that's just kind of a great spectrum of pathology that encompasses the mechanostat, in one nice package, is that you see every spectrum. If bones are overloaded, they are going to response, they're going to remodel. And it's important for us, just me as an imager, as a muscular radiologist, to say, that bone is telling me something. This is at risk for an injury, and we want to catch it early. So the reason it's important to understand things like Wolff's law and mechanostat is to think about, well, what is this image telling us in terms of the pathophysiology and the histology of bone? And just that little fluid, that tiny little fluid along the anterior course of the tibia in that setting tells us this is a setup for a stress fracture. And again, most of these patients come in and it's obvious, but these subtle patients are really ones we want to pick up because we can help prevent things progress to that fracture state.
Got it. And that's a great explanation of some complicated theories. We will have this on our YouTube channel, like I said earlier, Dr. Silverberg's slide that explains it. So refer to that often. I do want to ask you something that I didn't put on the script, just out of curiosity.
Sure.
Let's say and common things occur commonly. You see a fracture on a radiograph, it's the same. I'm sure there's, similar findings with MRI. But if you see something that's suspicious, is there a way to measure the density of that material or that anatomy and compare it to something else that would say, oh, this is not good, this is more likely this, or even with bone, like you were talking about, the tibia stress fractures, the osteopenia, can you measure the density of it or kind of get I think in CT it was called a region of interest, where you could measure it and compare it to other anatomy and kind of get an idea? Is that ever something that you would use?
It's a great question. And I can tell you were a CT tech in the past. Essentially, we can't measure density because the physics work differently, unfortunately. But there are some things we can use. And so, I guess one other question is are you looking to say, is this a pathologic fracture, regular fracture, or is there something else in bone? Like, is this an infiltrative process rather than marrow edema? Is that sort of the root of the question?
Exactly. And
Yep.
and if we take that a step further, we get the MRI and it comes back and it says, well, it might be this, it might be that, further imaging. And I'm just trying to help our listeners understand why you can't always use this modality and say that's what it is. We need another modality to kind of better define it.
Gotcha. Yep. So going back to soft tissue contrast, because I think this plays a role in our ability to diagnose. When we talked about sequences, I'm saying, this thing is bright on T1 or it's dark on T2. My bright might be different than your bright. So when I say something is bright, you may say, it's intermediate, it's kind of mildly bright. I don't agree with you saying it's very bright. So we need a reference. And our reference in musculoskeletal imaging is always skeletal muscle. So if I say something is bright, I always mean it's bright relative to skeletal muscle. And if I said something's dark, it's dark relative to skeletal muscle. And the reason that's relevant, that soft tissue contrast is relevant to this concept of bone pathology, is we have a very fortunate soft tissue contrast difference in bone. We have cortical bone, which is dark, and we have medullary bone, which is bright because of the medullary fat that exists. Fractures and contusions, well, we'll get into contusions in a bit. Fractures disrupt the trabeculae within medullary fat. So we see a nice clean path of that disruption as a fracture line. Bone contusions are microtrabecular fractures, meaning they're little tiny areas of the trabeculated fracture, but they don't coalesce. They don't form one dominant fracture line. They're sort of separated out in space, right? So they're technically microtrabecular fractures, but we don't call them fractures. So they're not forming one big fracture line. But in both of those scenarios, the medullary fat that's disrupted is disrupted by a fracture. In tumors or infiltrative lesions, they don't respect the boundaries of medullary fat. They replace it, right? They're destroying bone. They don't care about going along the path of least resistance that a fracture line takes. They'll go anywhere. So when we look at medullary fat, it's very important to look at a non-fat saturated image because that fat helps us to determine whether or not it's replaced or destroyed. Take a tumor, for example, or take lymphoma or anything that infiltrates bone, even osteomyelitis. That is going to replace and destroy medullary fat. And the way that looks on MRI is dark. It's going to be dark, right? Because it's this infiltrative process replacing bright fat. And if the fat's replaced, it's no longer going to be bright because it's not there anymore. So one thing other than density that we can use is the signal intensity. So typically, contusions are going to be either occult, meaning we can't see it because it's going to be bright, or they're going to be brighter than muscle on a T1 non-fat saturated image. Fracture lines are typically darker than a muscle on a T188 image. However, a fracture line, like I mentioned, is going to be linear and well-formed. If we see something that is darker than muscle and is not a fracture line on a T1 weighted image, that gives us pause because that says that marrow fat is potentially being replaced and might be a tumor. If we see a cortical fracture line, it's nice and distinct, it's game over. That's a fracture, we're done. Most tumors that cause cortical disruption don't do it along clean planes, right? It's not going along the path of least resistance. That's a tumor eating away or kind of breaking out of its cortical shell and not going along a finite path. So to answer your question kind of succinctly, we don't use density, but we use marrow replacement and we use the soft tissue contrast created by that T1 bright fat being replaced as our kind of equivalent. There are also some more technical things we can do, and I'll just mention this briefly just so people are aware of it, but this kind of gets a little bit more complex. There's something called a post-phase imaging, and a post-phase imaging basically just looks for medullary fat. So if I have a case, let's say I see this patient, they come in, they had mild trauma that doesn't really fit a contusion, but there's something, it kind of looks like a contusion, and I can't tell, is that medullary fat preserved or not? It technically should be brighter than muscle or occult on a T1, but there's something that's kind of, it's close. It's close to muscle. We can do what's called a post-phase imaging, and basically it looks for microscopic fat. And if there's microscopic fat in an area that we're considering as a tumor, it's unlikely to be a tumor because, again, tumors replace that fat. So that's the best equivalent we have compared to CT density is the medullary fat being replaced and destroyed? And if so, it should be darker than skeletal muscle. It should be ill-defined and not forming a fracture line. And that's the best equivalent we have compared to CT.
Great. That's awesome. Awesome description of why you get the reports, what it means when you get the reports. Some of the terminology is right on spot. I mean, it just helps you to understand what's going on by knowing the background in this. Dr. Silverberg, thank you so much.
Likewise. Thank you guys, and I really appreciate it.
Listeners, follow along on our YouTube channel. We'll have several images of Dr. Silverberg's talk that correlate with the podcast, so please follow along there. And for our listeners that would like to see Dr. Silverberg's presentation at our conference, again, it'll be on our website soon.
Our annual meeting this year is called Ortho in Indy. It's from August 21st through August 25th. The venue is the JW Marriott. Not only do we have world-class speakers, we have workshops, optional mini sessions, food, social events. There's just tons of things going on. We hope to see you there.